Hello everyone. This is a case of a recurrent extra-axial CNS tumor, and this case highlights the importance of precise diagnosis in diagnosing recurrent tumors. So this is a 51-year-old man with third recurrence, previously operated in 2019, 22 and 23. We received 9 blocks for second opinion and immunohistochemistry. Now the excised tumor was extra-axial masses with intra-axial component in the right temporal region and multiple masses in the frontoparietal region, which were diagnosed as meningioma on histopathology for all the 3 excisions in other laboratory. The true cut biopsy of anterior mediastinal mass was diagnosed as thymoma. The CT scan revealed a mediastinal mass before the second surgery in 2022. Imaging findings were suggestive of recurrent meningioma. Now, these are the preoperative findings of 2023. Postoperative status with right temporoparietal craniotomy noted with areas of gliosis in the right high parietal region. There appears to be areas of large lobulated T1 and T2 hyperintense lesion in the right temporal and frontoparietal region that measured 79 into 47 mm with mild to moderate surrounding edema and moderate enhancement, likely to be recurrent meningioma. Histopathology showed presence of a compact cellular tumor admixed with hypocellular areas. Now, on the lower power, you can see that the vasculature is very typical. These are dilated ectatic vessels, blood vessels, and this vessel is showing staghorn-like pattern. Now, whenever we see this type of blood vessels, what comes to our mind is a solitary fibrous tumor. Coming to the cellular arrangement, so the pattern is haphazard or patternless pattern, and this pattern for the solitary fibrous tumor was first described in early 90s by Dr. Stout. You can see some foci have storiform pattern. Now coming to the blood vessels, these vessels are dilated and there is a thick band of collagen around the blood vessels. You can see this is sclerosis or hyalinized vessels, which is merging with the intervening stroma. So the cells in the solitary fibrous tumor are monomorphic. This is typical of tumors which show translocation. For example, solitary fibrous tumors, synovial sarcomas, and mesenchymal chondrosarcomas show translocations. The cells are ovoid to spindle with monomorphic round to oval or elongated nuclei. Pericellular collagen is present. SFTs may show ropey collagen or collagen in form of thick bands. Mitotic activity in this case was more than 5 per 10 high power field, foci of necrosis present, and the Samoma bodies which are typically found in meningioma. This is histopathology of the anterior mediastinal mass true cut biopsy, and you can see there are similar features. So these are dilated blood vessels, some exhibiting staghorn pattern, and the typical monomorphic round to oval cells as found in the brain mass, and was also areas of necrosis found. So some SFTs may show myxoid change or multinucleated tumor dense cells. Some may have prominent adipocytic components. And there is also variant called as dedifferentiated solitary fibrous tumor. This is the immunoprofile of a right temporal mass. The strong nuclear STAT6 positivity was observed. Now, immunohistochemistry by STAT6 is more reliable than the molecular studies such as FISH in the tumor showing translocation. CD34 was focally positive. Now, CD34 is not a specific marker for SFT, and it can be positive in other fibroblastic or even the vascular tumors. And one must remember that as the grade of the tumor increases, the CD34 positivity may reduce. So, EMA negative ruled out the possibility of meningioma. GFAP OLIC2 negative ruled out glial tumor. CK negativity ruled out a metastatic carcinoma. And the Ki-67 proliferation index was much higher, that is 15 to 18%. Now, this is the immunoprofile of the anterior mediastinal mass, and you can see there is strong STAT6 nuclear positivity. So, the diagnosis we rendered was a solitary fibrous tumor, CNS WHO grade 3. Uh, the previously used terminology SFT oblique hemangiopericytoma or hemangiopericytoma is an obsolete term now. The pathogenesis is genetic hallmark of NAP2 and STAT6 genes due to the genomic inversion at 12q13 locus. Histologic grading is composed of mitotic activity and tumoral necrosis, which correlates well with the prognosis. Now, there are three grades, the mitotic, taking into consideration the mitotic activity and the necrosis. So, in the grade 1, the mitotic activity is less than 5 per 10 hyper field and the necrosis is absent. For grade 2, the mitotic activity is more than 5 per 10 hyper field with absent necrosis, and for the grade 3, the mitosis should be more than 5 per 10 hyper field with presence of necrosis. So the differential diagnosis include both meningeal and soft tissue tumors such as fibrous meningiomas. Now this is a EMA positive, EMA or stomatostatin receptor 2A positive tumor, and these will not exhibit CD34 and STAT6 positivity. The dural-based Ewing sarcoma will show NKX 2.2 and PAX7 positive, and these are STAT6 negative tumors. Primary and metastatic monophasic synovial sarcomas are EMA and TLE positive, and they will show SS18 gene rearrangement on fish. Now, mesenchymal chondrosarcoma can be differentiated due to presence of well-differentiated hyaline. The diagnostic molecular pathology is NAP2 STAT6 fusion, which can be demonstrated by sequencing and RT-PCR, and this is often challenging. Fortunately, IHC detection of strong nuclear STAT6 is sensitive and a specific surrogate for all. Treatment of choice is surgical resection with supplementary radiotherapy and chemotherapy if necessary. Prognosis and prediction: incomplete surgical resection may lead to recurrence. Meningeal solitary fibrous tumors have high propensity for recurrence and metastasis, and even low-grade SFTs may. Just concluding this case, I would like to tell our junior or the budding pathologists that whenever a diagnosis of meningioma is given on imaging, don't rush to give a histopathological diagnosis as meningioma. Fibrous meningioma is a closest differential diagnosis of SFT, and imaging cannot differentiate between the two. The dural tail sign may be present for solitary fibrous tumors as well. SFT is a mesenchymal non-meningothelial tumor. Histopathology is important to establish the diagnosis, which is confirmed by STAT6 nuclear positivity on immunohistochemistry. STAT6 is a sensitive and a specific surrogate marker as compared to the molecular detection methods. So it is very important to differentiate meningiomas from SFTs because meningiomas are relatively very slow growing tumors and the duration of the recurrence is shorter than SFTs. Even low grade SFTs are known to metastasize, whereas meningiomas do not metastasize so frequently. And the treatment of modality here includes radiotherapy and chemotherapy. Thank you very much. I hope you all appreciate this case, and you can subscribe my channel for some more interesting cases.